Thank you very much, everyone. I know we're pressed for time, but I still want to spend a couple of minutes giving a shout out to you, Remo, and your team. I want to congratulate you, Donna, your wife, Maya, your daughter, and Tina for another successful meeting. I heard that you crossed over 500 attendees. It's very impressive. And the plan should be 1,000 in the year 2030. Absolutely. And also, I would like to start with the good news. And the good news is not about me. It's about Maya Birire. Maya was just accepted at medical school, and that was something that Rimu and Dana enjoyed, and we would like to share your enjoyment with that news. And congratulations, Maya. So he wants me to do 2 40-minute lectures into 30 minutes, and I'll do it. And if there are questions, we will handle them maybe at the town hall. Chronic myelomonocytic leukemia can be operationally classified into what we call myeloid neoplasms with morphologic dysplasia. Now, the typical entity there is myelodysplastic syndromes, but a number of myeloid neoplasms can have also dysplasia, including acute myeloid leukemia, MDS, MPN overlap, CMML, of course. And the only one missing here is myeloproliferative neoplasms. They usually don't have morphologic dysplasia. They might have morphologic atypia, but not morphologic dysplasia. So I thought what would be nice for the audience is to have a nice, practical, easy way of differentiating this otherwise intimidating-looking diseases, which are actually not very hard. They're not very hard because our nomenclatures are man-made. They're not biologically sound. We just sit around a Starbucks table and we say, we'll call this this, we'll call this that. So according to the international consensus classification, when you have a patient with morphologic dysplasia, the first thing you ask is, what's the blast number? The blast number, by the way, blast means blast plus, promyelocyte is also a blast, promonocyte is also a blast, so they're considered blast. Is it 20%? If it is so, it is AML, no more discussion. That's the first question. The next question should be, believe it or not, what is the monocyte count? What's the peripheral blood monocyte count? Not whether or not the blasts are between 10 and 19%. What's the monocyte count? Because if the monocyte count is 500 or more, along with 10% representation, then that's CMML. That's chronic myelomonocytic leukemia. I don't care whether the blasts are between 10 and 19%. That's CMML. Then the next question you ask is, all right, blasts are not above 20%, monocytes are not greater than 5. The next question you ask is, what's the white count? If the white count is over 13, then that becomes immediately MDS MPN. Then you're left with just MDS. And in order to make a diagnosis of MDS, the blast has to be below 10%, because otherwise it will be AML MDS. So this simple algorithm will tell you exactly how to allocate what disease where. CMML is just excess monocytes. I want to remind you that there are the beautiful monocytes with nice bifolded nuclei, bilobed, gray cytoplasm, and then there is a promonocyte, a little more immature. It's not lobed, it's indented, it's kidney-shaped. And then there is a blast. Then the question is, what are the criteria? As I told you, 0.5 with 10%, and nothing else. You have to exclude everything else, including molecularly defined myeloid neoplasms, such as tyrosine kinase gene fusion-associated eosinophilia, the myeloid lymphoid neoplasia. So basically, if you just remember, 500, 10%, nothing else. So how do they present? I'm going to focus on the 3 clinical manifestations that require treatment: high white count, anemia, and thrombocytopenia. Those are the 3 major manifestations. About a quarter of the patients present like that. And then there's everything else, which is noise. But what is not noise is CMML is uniquely associated with some weird manifestations, like gingival hyperplasia, like leukemia cutis, pyoderma gangrenosum, lysozymuria-associated nephropathy. Look at the creatinine. Very important. And then there's almost everybody with CMML has a mutation, some mutation. The question is not whether or not there is a mutation. The question is, are those mutations prognostically bad or good? There are only 2 good ones, the yellow ones, the yellow highlighted ones. TET2 and PHF6. Fantastic. Especially PHF6. If you've got a PHF6 and you don't have a bad mutation, probably you will not get leukemia. It's that good. And then everything else is bad. You don't have to remember DNMT3A, ASXL1, PTPN11, NRAS. No. Everything else, until proven otherwise. Then you can go to Google, okay, is this bad one? So basically, I think this is very important. All right. You diagnosed it, you prognosticated it. Now, how do you treat it? Simple. It's either hydroxyurea or hypomethylating agent. Nothing has changed. The same as when I was a fellow. Nothing has changed. Has there been a randomized study? Yes. Did it show anything? No. Survival, as you can see, the same. Oh, yes. The response rate is higher, but it doesn't last. Well, maybe they can go to transplant better. Perhaps. And maybe the progression to leukemia is lower if you're on decitabine. Maybe. But why isn't it that they live longer? That is the case. Well, maybe they die of toxicity. Whatever. It doesn't really matter. It's all noise. Survival is not impacted. So the question is, if you think that getting a complete remission is good, even if it doesn't translate into better survival, perhaps it can facilitate transition to transplant, then the question is, can we add additional drugs to get a better CR? Obviously, venetoclax, vitamin V, you can use it for everything. You add it, perhaps you can get a little more. But it's not only vitamin V, but you can add lenalidomide, you can get more. But the problem is, look at the survival curves. So we looked at this at the Mayo Clinic. We looked at 457 patients retrospectively, and we said, all right, did they get treated? And if so, what was the first-line treatment? And look at the survivals, all down. So if you're not changing their survival, then why are you treating them? Well, you're treating them for those 3 things. If it is a very high white count, you can give them a little hydria, control it. If it is thrombocytopenia, you don't necessarily have to use a hypomethylating agent. You can use Promacta, Eltrombobac. They respond. The problem is that it only lasts for 2 to 3 months. Then you can give them the decitabine. If it is anemia, you can use good old erythropoiesis-stimulating agent. In other words, you can use other drugs. And by the way, what if they're sick and the spleen is big? Not to worry. You could use ruxolitinib. These are all non-specific drugs. You give ruxolitinib to somebody with pancreatic cancer, they will feel better. non-specific, good-feeling drugs. The only thing that can help your patient with this disease is transplant. The only thing. And a number of studies have been shown. Overall, transplant results in better gain of life if it is done for a higher risk. If you do it for a low risk, they are probably better off not getting transplanted. In other words, if you have a lower risk disease, it can be deferred. If it is a higher risk disease, you do it right away. So the question is, how do you tell lower risk, higher risk? First of all, let me just share with you our experience at the Mayo Clinic. We just finished this, 138 patients with CMML that were transplanted. It is true, it works. 50% 5-year survival rate, very nice. And it also works even if you do it after they transform into blast transformation. It works, as you can see. But we also learned a few things. The outcome is better if at transplant the blast count is less than 5%. So get them in the chronic phase. Don't wait to go into blast transfer. And if they did, try to get them into remission before you transplant them. What else mattered? Well, we looked at everything. Donor type didn't matter. Conditioning. Myeloablative caliber busulfan appears to be a little better. But this is a small number of patients. You can't really say. But really, for the most part, it really didn't matter. But one thing we found, and I don't know if Richard Childs is here, one thing we found is that the use of post-transplant Cytoxan actually was associated with an increased risk of relapse. Yeah, they feel fantastic, no GVH, but then they relapse. With CMML, and we have also seen this in myelofibrosis, the use of post-transplant Cytoxan should be thought about before you do it. So how do I choose which patients to go to transplant and which patients it can be deferred to? So here is a new model that we just developed, very simple model. Does not require calculator, does not require you going to the web to find a calculator. It's very simple. 3 factors: anemia, leukocytosis, and is there any blast count in the peripheral blood? Peripheral blood blast greater than 2%, white count 13 or more, and severe or moderate anemia, defined according to gender. And you have this beautiful layering, and actually the predictive performance of this simple clinical model was not inferior to that of the molecular models that I have right next to you, IPSSM and CPSS-MOL. Simple. And then you might say, well, we're in 2025, 2026. I need mutations here. I want you to put some mutations. This is boring. This is too simple. Not to worry. Not to worry. Then I say, okay, first, use a globally applicable simple model, and then you say, within each that model, do mutations matter? And we were able to show that in low-risk patients, if we do this appropriate mutation screening, and we made it very easy, you either have a favorable mutation, an unfavorable mutation, or the mix of the two. And based on that, we can identify from the clinically low-risk group who should get transplanted because they're molecularly challenged. At the same time, from the intermediate risk group, we can find people who could do very well. Look at the figure 3B there. These are for intermediate risk groups by clinical modeling. If they have a good favorable risk or a low molecular risk, they can do as good as a low risk. So you can use mutations and karyotype appropriately within that context, and you didn't require any calculator. And it is even better when it comes to predicting leukemia. And I have to tell you this. We can predict who has a leukemia risk of less than 5% over the next 5 years versus who has a risk of 50% in the first year. Simple. And we have this. This has to be a combination of the two. But I want you to remember, PHF6 mutation, good mutation. If it is not associated with a bad mutation such as DNMT3A, then almost nobody gets leukemia. Well, maybe somebody will, but at least so far we haven't seen anybody getting it. I'm sure somebody will get it. Now, on the other hand, there are a number of factors which tell you that you're going to get leukemia. The bone marrow blast, intuitive. Peripheral blood excess, intuitive. High white count, intuitive. What is not intuitive is perhaps the mutations, DNMT3A and ASXL1. I want you to remember this too. DNMT3A and ASXL1 are bad for leukemic conversion in CMML. And therefore, this is the last slide of the first talk. How am I doing in time? Not bad, very good. So this is how I approach patients with CMML. I ask, what risk group are you in? If you are a low-risk group, I'm not rushed into transplant. The question is, if you are a low risk, should I use anything? I know they're not going to do anything. Why should I treat them with hydroxy or so forth? You might have to, because of symptoms, because of this, because of that. You might have to. But more importantly, if the white count is over 50,000, stay with me here. Over 50,000, you might get lysozyme-induced nephropathy. So use hydroxyurea wisely to keep the white count down so that you can minimize lysozymuria and lysozyme-associated neuropathy. If it is high risk, transplant. The question is, what do you use for transplant? What conditioning, what donor? We're not going to talk about that. All right. So should I continue? Yes. I have a whole 17 minutes left? Too much. Oh, there you go. This is not as bad as CMML. In the interest of time, I'm going to assume you know how to diagnose these cases. Myeloproliferative neoplasms, ET, PV, and myelofibrosis. So let's get into prognostication and treatment. 2,000 patients between Mayo Clinic and the University of Florence. What does this show? This slide shows 2 points. One is, this is a good disease. So please try not to kill the patients before their disease kills them. Very important. We're talking about over 3 decades expected survival. Any kind of clinical trial, the odds are it will show harm, as did anagrelide, than good, because it's such a good disease. Therefore, for me to be excited about a clinical trial in this disease, you have to show me a biologically activity, like a imatinib-like activity, cytogenetic remission, molecular remission, in order for me to be excited. Anything else? Lowering the platelet count? Now, how do you prognosticate in CMML? Well, you've heard of IPSET, you've heard of the AAA score. Now we have a new and improved AAA plus A. What's lovely about this score, it's all based on CBC. Nothing else. CBC, absolute neutrophil count, absolute monocyte count, and absolute lymphocyte count. And what's the plus A? Age. AAA plus A, wonderful, and you can distinguish survival. But I'll tell you what, this is not actionable. What are you going to do with this? It's not going to tell you, you're not going to take this patient to transplant just because they are high risk. It's still a good disease, even if it is high risk. This is just to get a general idea of what the future holds, and you hold the transplant as a parachute. So this is not an actionable. What is actionable is what's the risk of thrombosis. That's what we treat. We treat these patients with ET to prevent thrombosis. And here, things are different from the time when I was in medical student. There are now 3 instead of 2 risk factors. JAK2 has joined history of thrombosis and older age as a risk. And based on that, we have 4 risk groups: very low risk, intermediate risk, and high risk. And how do we manage them? Very simple. Is there thrombosis history? If there is no thrombosis history, you probably don't have to give cytoreductive therapy, regardless of the situation. That's the most important thing. As I always say, in this disease, we treat the patient, not the platelet count. Remember that. You can get excited about 2 million, but actually 2 million is probably better than 1 million because it makes them less at risk for arterial thrombosis. A high platelet count is a systemic anticoagulant, believe it or not. It's mechanistically and biologically sound impression. So if you have a thrombosis history, that's high risk, meaning that patient requires cytoreductive therapy. Now, in addition, it depends on whether it's arterial or venous, and you need systemic anticoagulation if it's venous, and if it's arterial, you need aspirin. That's not the hard part. The hard part is what to use, hydria, interferon, whatever. You could use whatever you want, but the evidence is there only for hydroxyurea. But you say, well, my patient is young, I want to use interferon. Please, go ahead. I'm not going to stand in your way. Interferon, hydroxyurea, reasonable. But I don't want you to treat them with ruxolitinib or this or that. These are patients who are going to live long. Don't shorten their life. Now, if there is no thrombosis history, then you have to try as hard not to give the patients cytoreductive drug. And is there a possibility that you don't have to? Yes. Age by itself is not a reason to punish patients with a prescription with chemotherapy. You have to look at the whole thing. So even older patients, if they don't have a JAK2 mutation, I don't necessarily use hydroxyurea or anything. Aspirin twice a day is enough. How about the younger patients? Younger patients, the question is not about cytoreductive therapy. The question is aspirin or no aspirin or aspirin twice a day. Simple. JAK2 mutated, aspirin twice a day. Triple negative or type 2 CALR, no aspirin. Yeah, you can give aspirin if you want to, but you don't have to. Anything in between, 1 baby aspirin a day, especially if it is type 1 CALR. Anything in addition? Well, Dr. Gangat has been working very hard to resolve your recurrent questions about pregnancy, the platelet millionaires, what am I going to do? And we've done a lot of studies on this. And the bottom line is pregnant patients, 1 baby aspirin, period, low risk. High risk, add interferon. 1 baby aspirin reduces the recurrence rate, the miscarriage rates, and so forth. It's the best treatment. Platelet millionaires, let them enjoy their platelets because they are on systemic anticoagulation. You don't have to treat them. But sometimes people get very anxious, and sometimes anxiety is worse than thrombosis. Yes, if you need to treat their anxiety, treat it. In this instance, though, don't give them chemotherapy, perhaps a little interferon. Polycythemia vera diagnosis is not as hard as anything. It's very simple. You got a JAK2 and the hemoglobin is up, it's PV. What do you want from me? Do you need a bone marrow? No, you don't. That's PV. The problem is, there's 2 things I want you to learn from here. Number 1, 90% of the time when I'm asked to see a patient with erythrocytosis, it's not PV. It's secondary. And here, I want to remind you, if this is the only thing you take from this lecture, I'll be happy. Gliflozins, SGLT inhibitors, Campad, Cana, DAPA gliflozins. These are now promiscuously being used everywhere. Kidney disease, heart failure, diabetes, and they all cause elevation in erythrocytosis. This is an easy consult. Grab it, get your money, and say, don't worry, And the other thing, they don't have to stop the gliflozin. We've looked at it very carefully. There is no increased risk of thrombosis. You will hurt them by depriving them of the gliflozin. JAK2 mutated over 1%, easy. JAK2 mutated 0.5%. That's when maybe you need to do a bone marrow, and you need to look at other things. Monocytes reign again. We also have another AAA plus A model. This is the revised international working group. We're preparing the paper now. But here the difference is the AAA plus A, the plus A now, it's not absolute lymphocyte count. There is a switch here. Absolute lymphocyte count is not here. Here we have arterial thrombosis. That's it. AAA for ET, AAA for PV. Just to remember that arterial thrombosis replaces absolute lymphocyte count in PV. Simple. Medical school. Low risk. Older, age below 60, below 70, below whatever you consider low. No thrombosis history, low risk. Otherwise, high risk. This is what we learn. And how we manage? Well, if it's low risk, just aspirin and phlebotomy. If it is high risk, add hydroxyurea. And if the hydroxyurea doesn't work, switch to interferon. Simple. But then the question is, we need to make money here. We can't just go, we need to publish, we need to make, pharmaceutical companies need to make money. So the question is, well, maybe we should give interferon to low risk. Maybe. Maybe instead of Hydrea, we should use interferon or ruxolitinib. Maybe instead of interferon as second line, we want to use. This is all pushed through marketing, period. We want to make money. Because these patients don't die. They live forever. So that's a revenue that lasts forever. So I'm not surprised that drug companies are really pushing into finding something they can put you on forever, whether it does good or bad. So, number of phase 3 trials has been done. They've been done up front. They've been done after hydroxyurea treatment. And I'm not going to bore you with the details of this. I'm going to tell you the punchline. None of them have shown any superiority over hydroxyurea. None of them, in terms of meaningful health outcome, survival, leukemia, thrombosis, none. So what happens? Well, we spin it out. Better hematocrit control. Better this. Quality of life is better. Fine. Obviously, if somebody is suffering from quality of life, we'll do whatever in order to make. But in general, they are not superior. So based on that, this is what we currently follow. If it is low risk, phlebotomy and aspirin. But sometimes, some people have a high phlebotomy burden. They need frequent phlebotomies that become iron deficient. Yes, those need to be treated with some sort of myelosuppressive drug. And here, if it is for the high, I would probably use interferon as opposed to hydroxyurea, if that is the case. Now, there are some new drugs coming up. We will see. High risk, simple. The usual, hydroxyurea plus phlebotomy plus aspirin. You say, well, Dr. Tefferi, interferon is good and JAK2 allele burden goes down. You could do whatever you want. Nobody has shown that this little drop in JAK2 allele burden translates into biologically meaningful extension in life or reduction in complication. It's an epiphenomenon. Perhaps it's a good guardian angel. You want to get rid of it and you come up with something else. But that's where things are at this point. This is a killer. This is not a good disease. Not only does it shorten your life, I'm talking about myelofibrosis, but it also makes life miserable. And the three major quality of life offenders here is huge spleen, you can't bend, profound constitutional symptoms, and then transfusion-dependent anemia. So here, you want to treat to prolong life or improve quality of life. And if you want to prolong life, the only thing that can do it is transplant, period. You want to discuss with me how ruxolitinib or something maybe can prolong life? I'm not interested in that conversation. I got work to do. Now, if your objective is not necessarily to prolong life, then there are many drugs you can give to make life palatable. And here, obviously, the JAK2 inhibitors are wonderful. Fortunately, transplant is becoming more and more doable. You can do it in older patients. Average age is now 60. It could be 70 soon. And not only that, but you can also transplant from anywhere. Everybody's got a donor now. You don't have to have an HLA identical sibling donor. It could be a haploidentical, it could be anything. You can do it. That's the only thing. If your objective is to cure or prolong life, that's the only thing that you can do. Very good paper came out in New England Journal of Medicine in the last month. And it shows you how you can predict outcome after transplant. After all, transplant is the only game in town when it comes to cure. So the question is, how can I know when relapse is low? Very few things, but the most important thing is the day 30 clearance of the driver mutation. So you're a JAK2 mutated myelofibrosis, you get the transplant, on day 30, no JAK2, you're good. Less than 10% risk of relapse. A little bit there, not very good. Is this actionable? Perhaps. Perhaps we can intervene with donor lymphocyte infusion earlier, much earlier and harder. If you can transplant, then JAK2 inhibitors. Now we have 4 that are approved. And the question is which one to use? Well, I'll give you my own opinion. I have used these drugs for the last, I don't know how many years, since 2011 or what have you. And we have a very long follow-up. Momelotinib has an edge from everyone else in terms of anemia. If anemia is an issue, you're better off starting with that. In addition to its effect on symptoms and spleen, of course. Ruxolitinib has an edge in terms of being clean. Side effect, everybody tolerates it very well. Beautiful drug. Momelotinib is not everybody tolerates it very well. But these are the only 2 drugs that I use. Well, what about pacritinib and what about fedratinib? Well, we've done the real-world study. We're not impressed. I'm not going to go into details. Maybe just a little bit of a detail. Fedratinib. If you switch to fedratinib after you have an appropriate dose of ruxolitinib, 20, 25 twice a day, doesn't do nothing. But if you stop it at 5 milligrams twice a day, yes, then it works. It's a dosage phenomena. It's not because one drug is better qualitatively than the other. How about pacritinib and thrombocytopenia? Any of these drugs, if you don't give too much, you can use it in thrombocytopenia. And by the way, thrombocytopenia 20, 15, 25. So what? I'm a hematologist. I deal with thrombocytopenia much less than that. If the benefit outweighs. And so based on that, as I have said, if you can transplant, transplant. If you can use, otherwise you can use these drugs. For the anemic patients, I prefer momelotinib. Otherwise, hydroxyurea followed by ruxolitinib. These drugs do not prolong life. And everything new that is now, pelabresib, selinexor, all this jazz, yes, you could have deeper, you can have more shrinkage. Well, who cares whether you live with 15 centimeter versus 10 centimeter, especially if in exchange you become transfusion dependent. The toxicity benefit ratio is not necessarily the best. Instead, take it out. If the patient's spleen does not respond, take the spleen out surgically. We've just published this. I'm not going to go into it. Viable, especially if you're preparing for transplant. And the whole new field now is a different pathway. Everybody knows about JAK-STAT, but how many of you know about the SMAD pathway? That pathway appears to be the central pathway for ineffective erythropoiesis and iron-restricted erythropoiesis. And therefore, there are many molecules you can target, and we're targeting them, and we are getting good responses in anemia. How about specifically to the mutant molecules? Yes, there are ongoing studies looking at monoclonal antibodies that are specific to mutant CALR, and perhaps next generation JAK2 inhibitors. The fruit, the pudding is in the fruit, or the fruit is in the pudding. We'll just have to wait. And this is it. I think I have done in time. And I want to thank all of you. I will probably address some questions you might have tonight.